Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. And I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, thanks, Pete. How are you?
Oh, I'm doing great. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Today, we have an episode on a topic that almost never fails to create a debate, which is whether or the beach chair or the lateral decubitus position is better for shoulder surgery. We've invited two experts on, one to advocate for each position. So first, in defense of the beach chair position, we have Dr. Brett Owens from Brown University. Brett, welcome to the podcast.
Well, I'm really excited to be here. Thanks for having me.
And then next, in defense of the lateral decubitus position, we have Dr. Ivan Wong from Halifax, Nova Scotia. Ivan, welcome to the podcast.
Thanks for inviting me.
Okay, let's get started with the first point, which I think is that often people claim that what you do depends on how you are trained. So let's go through your training. So tell us, Brett, what did your mentors do? Did that influence you here?
Yeah, well, I'd like to start off by really noting that I'm a little bit outnumbered here. I know, Pete, both you and Rachel are proponents of lateral decubitus, but that's okay. I'm going to hold my own. I can handle it being 3-1.
We shall see about that.
Yeah, I mean, I had a journey, I think, like many people do. I trained at University of Massachusetts with Brian Visconti. We were all lateral decubitus. And then my fellowship at West Point, and then at time at HSS, we were almost all beach chair. I think early in my practice, I experimented with both, and I've used both at different times when I was at different institutions, just because it was easier at that institution. And but I've really now fully embraced a beach chair position, and I haven't really looked back. Every now and then I'll experiment in a lab situation. It's always fun, but I've been pretty happy in the beach chair position.
All right, tell us, Ivan, the people who trained you, what did you do? What did they do, and how did they influence you in terms of what you do now?
Yeah, absolutely. So, no question, people that train me had lots of influence on what I do and how I do it. I did my residency at McMaster University in Hamilton, and there everyone did, or majority of people did beach chair, so that was my exposure. And then did my fellowship at Southern California Orthopedic Institute with Steve Snyder and his team, and almost everyone there did lateral decubitus. And so, experimenting with that, observing all the cool and intricate procedures and whatnot, I've moved on to really taking on the lateral decubitus for both shoulder instability and cuff work.
It's interesting that both of you guys had two different exposures in training and really seemed to gravitate toward what you potentially learned in fellowship more. Do you think that's because you were more the primary surgeon in fellowship compared to residency, or just because that's the latest thing that you were exposed to in your training before starting practice? Because in contrast, both Pete and I trained in residency and fellowship in predominantly lateral trained surgeons or under lateral trained surgeons, especially for instability. Cuff, different story, and we'll get to that. But we both had similar experiences in residency and fellowship, whereas you guys had different ones. Ivan, do you think, it's just the timing of fellowship that influenced how and why you started practice that way, or is it, or it just something that you've just liked more?
Yeah, it's tough to go back and figure out if it's the timing versus what you actually see. Because in residency, as you might remember, you're really doing a more general practice. You're only there for a few months at a time. You're switching from staff to staff. Whereas in fellowship, you're really focused for a year, and you're focused on the more advanced type of technique. So for me, I saw more advanced techniques during that year, and because of that, I got more of the tips and tricks, and that's what I actually took back. Whether that was because it was later on in my training or being a year or whatnot, no matter what, I think it's just because I could apply more advanced techniques. That's why I want to continue on that type of a position.
Brett, same for you or different, or what do you think?
Yeah, I haven't thought about it before, but I think it's a great point, Rachel. And I would say, I guess I would echo what Ivan said. I think it is probably because you're a little bit later, a little bit more mature, and maybe you are doing more advanced things. And I mean, I think this is a great topic, and it's funny that this still does, generate a lot of discussion. But I think, I tend to believe that, either position can work well. The question is, what works well for you?
All right, let's start at the beginning. I want to ask both of you guys, do you think it's harder or easier to position the patient in beach chair or lateral? And let's take into account, especially for our younger listeners who might be exposed to both setups and they're thinking about what they're going to do in practice and what's most efficient for their surgery center. If they combine shoulders with, say, knee surgery, and if they're using different setups, lateral is obviously easier to transition to a knee surgery setup versus beach, which requires in many cases a different table, or at least some different apparatuses to help with the table. So, what do you guys think is easier to set up? Ivan, let's start with you. Beach or lateral?
Yeah, that's it depends on what you mean by easier. Just like you mentioned, you require different equipment for each, and we don't even need to just get into the table per se, right? Because you just mentioned the table's different between beach chair and lateral. No question, lateral very similar. You can use with all kinds of other things. But once you start talking about lateral, you have different arm positioners. You have a spider positioner. You have several other versions of that, or you have a suspension mechanism that you can use, or you can just use cables going off the bed with IV poles. So there's so many different variations of that. Ease or not ease, you got to choose a mechanism of what you have. And so really, I actually changed from what I did in fellowship to what I do now based on the different procedures that I want to do. So I think more than just what's easier or not is figuring out what you want to do and having a setup that can allow you to accomplish all of that.
Brett, how about you? What do you think is easiest to set up? And, I think keeping in mind when you work with residents and fellows and potentially they're setting up the patient for you if you're not in the room or not completely in the room during the entire setup, what's easiest and most reproducible for you in your practice?
Well, I don't go back and forth now, so I think I'm very happy with, beat your setup. You know, those my colleagues that like lateral decubitus think it is faster and easier. I agree with the bed. Definitely switching out the bed sometimes impacts your flow of the day if you stack your shoulders at the beginning or at the end. If you're interposing them with knees, um, you know, I think there are some in the beach chair position. Oftentimes, the anesthesia impacts the ease of setup or not. When I was in the Army, we almost always, again, they were all, usually 20-year-olds, right? And so very healthy. They're almost always just a block and Mac. Um, when I transitioned to civilian practice, there was a lot of resistance to moving uh, away from having any sort of airway control. So they almost always wanted an LMA in, which certainly added to not only the time of induction, but also more difficult setup sometimes because the patient is kind of floppy and not able to help at all with positioning. And I find that sometimes with a block and Mac, it's a lot easier for me to set up than it is sometimes if they're completely asleep. Probably the only nice thing about the COVID experience has been, at least in our hospital and our outpatient facility, they're much more open to trying pure regional now under COVID than they were prior to.
Rach, when you do beach chair surgery, are you doing any of it under block and Mac, or are you guys all general at your place?
It's variable during COVID, same as what Brett was mentioning. We started toying around with just doing Mac, but I would say vast majority, over 95%, general and regional. How about you?
We've been all general, but I've talked to our anesthesiologist about transitioning. I think ultimately it doesn't matter. It's whatever works. There's another aspect of the anesthesia I want to talk about, which is traditionally there's been this argument that the lateral position is safer for cerebral perfusion specifically. So I wanted to ask each of you guys, does this play into it? Are there certain patients that you worry about? You say we got to go lateral for this one because I'm worried about, not enough blood getting to the brain. Have you ever had a problem with this? Does this change your perception of, the blood pressure and hemostasis? Ivan, what are your thoughts?
Um, I don't think I would actually choose choose a patient to go lateral versus beach chair, considering, I really do everything lateral, except for AC joint reconstructions. Um, But what it does let me do is ask them to get hypoperfused. So I ask them to keep, a MAP of 100 or less so that I can keep my pump pressure as low as physically possible. I go somewhere between 20 to 25 mils mercury with a double pump, so that really can decrease the amount of extravasation of fluid, and then they tend to have a lot less pain afterwards and a lot faster return to function.
What are your thoughts, Brad? I mean, you're a beach chair advocate here. This has
Yeah.
traditionally been an attack point for beach chair. What has been your
Yeah. I would hit on a point that you were mentioning earlier, Pete, and I would push you to try a couple of Mac and block, because the setup is so much easier in the beach chair position, especially in your teenagers, right? They're healthy. Usually the anesthesiologist won't give as much pushback on doing just a Mac with the block. Sometimes you need a little bit of local in that posterior portal, because it's a little bit out of the range of the block. But again, it can make everything a little bit smoother. That's a great point. I am a sports surgeon primarily, and I don't do a lot of older patients. So the majority of my work is instability, and even the cuffs I do are usually in their 50s or early 60s. And so certainly a younger population than some, and certainly it's the older population we always worry about cerebral hyperperfusion. I think it's a real concern. I tend to not have as much instruction with the anesthesiologist as far as my math, like Ivan does, and tend to probably run my pump a little bit higher. I probably get um, more extravasation. That's probably why my videos don't look as good as Ivan's.
Both of your videos are quite excellent. Let's get into the meat of this. This is where the gloves come off. We want to know, and our listeners want to know, why each of your positions is better for instability. Brett, let's start with you because, again, as you mentioned, we've got between the four of us, three lateral people here for instability. Why is beach better?
Yeah, I'm happy to take the gloves off, but I tend to not throw a lot of punches with this, Rachel. I think that beach works for me, and it works for a lot of others, and I tend to not proselytize on what I do and say that that's better than what someone else does. The bottom line is I think you can do a good or a bad instability repair in either position, right? I think just saying, oh, I'm lateral decubitus position, therefore I have, you know, I mean, I've even seen the term modern technique used, right, to describe just based on the position, but it has nothing to do with how you're actually doing your surgery. I think it has a lot more to do with the surgeon and the technique than it is just about the position. I would say that, you know, I think I never changed from beach chair because I didn't find anything I couldn't do. I wasn't really frustrated with things. Now, I agree. This is where it does get fun. I see the advantages of this things that I appreciate are easier in the lateral decubitus position, especially in instability, especially Hegel's. Really wanting to see inferiorly, that distraction. Really, there's nothing really, quite like it in the lateral decubitus position. But I think you can get a really good instability repair in the beach chair position, and there are other advantages as well. That if you're a lateral decubitus surgeon, you'll also recognize the advantages of the beach chair position.
Well, that was a very polite answer, and I love it. Ivan, are the gloves coming off? Is Brett right, and it's what's best in your hands, or is lateral, in your opinion, a better position for instability?
Well, I really like actually how Brett put it, because you can do good surgery in a lateral position, but you can also do bad surgery in lateral position. Because I've seen people do instability surgery laterally, but do everything viewing from the posterior portal. I think what lateral allows you to do is make it is what Brett said, is what makes it easier to see better. And at least what I think is you can see better if you view from the anterior superior portal, where you can see down the front of the shoulder, down the back of the shoulder, and do all your work from the front and back. And so you can do this from beach chair or lateral. There's no question about it. I've seen lots of videos showing it. It's just a lot more ergonomically correct in a lateral decubitus position because you're not holding the scope above your shoulder height, and it allows you to work both front and back, not fighting with your assistant, not going around a different way. By ease, it makes it more likely that you're going to view from an easier portal and potentially have a more consistent, reliable result. With many of the studies kind of proving that you can get to the certain position that you want more consistently.
Yeah, I think looking at the literature is really interesting, and I know maybe some of your questions are gonna go that way. I mean, there definitely are papers that show that you can get to a certain location better in the lateral decubitus position, right? There are papers that prove that surgeons are able to put maybe a 6 o'clock anchor, and if that is what your proxy is for a good repair, right? You can definitely get a 6 o'clock anchor in easier in the lateral decubitus position, but there's no data suggesting that outcomes are superior in one position versus another. And I know Rachel's going to jump in, and hopefully we can talk a little bit about her paper.
Yeah, I think it's an interesting question. When we put together our paper from now, I mean, a long time ago now, so it'd be interesting to update this or update this literature with a new systematic review or meta-analysis. When you pool a bunch of studies, many of which are poorly done, and we all know data in equals data out, the pooled analysis would show that when you account for a lot of different factors, including number of suture anchors, et cetera, that the recurrence rates are statistically and clinically significant, favoring the lateral decubitus position. But there's a lot of caveats and nuances. And every time I presented that study when we first put it out, we there was a lot of questions at the podium about this and that and whatnot. And I would tend to agree with the sentiment that's been said throughout this entire podcast so far. And you can do good surgery and bad surgery in both positions. And so I think it really does come down to what's best in your hands for your patient. Personally, and I think I'm biased by the way I was trained. I find myself most able to visualize the inferior aspect of the shoulder, both posterior and anterior, in the lateral decubitus position with the traction in a more ergonomic fashion where I'm not working as hard to get my anchors low and to bring my capsule up. So for me, that's an easier way to accomplish the goal. And I think that the literature is interesting because there's a lot of good studies that show good results with beach chair and same with lateral. When we pulled that data, 5-10 years ago now, it favored lateral, but again, a lot of nuances to doing a systematic review.
Yeah, I mean, Rachel, I've looked at your paper, and I really like it. I think the studies go back though to like 1990. And I know you excluded sure tax, but there have been multiple studies that have shown that there is a temporal bias with instability reporting. We showed that around the year 2000 that may be somewhat of an inflection point for arthroscopic anterior instability outcomes, as there were a lot of technical advances in the 90s. And a lot of these papers, really, I'd love to go back and look based on the year of publication, because again, a lot of the papers skew a little bit later in the posterior series. The thing is, looking at that, again, you had a few statistical outcomes, but the one I have in front of me here was like, beach chair had a 3.6% failure rate, right? And lateral decubitus, this is on the regression analysis, right? The lateral decubitus had a 2.3% failure rate. Now, I know it's statistically significant, right? But we're talking 1%. And I don't know. I just think it's interesting. That's one study, but there have been other groups. It'll be interesting to see what the Moon group comes out with. They were able to look at this, prospectively, good surgeons looking at it, and they found, more anchors put in. So the implant companies are happy with lateral decubitus, but we're yet to see kind of what the outcomes are. And there are other series, our series from the military, which has only been presented and still in review, but has not shown any difference as far as outcomes of lateral decubitus or beach.
I think those bigger prospective database studies will be so helpful. Even bigger retrospective database studies where the surgeons and the technique are very limited, so there's less variables to consider, will be super helpful. And yeah, you make a great point. It's a 1 percentage point difference that allowed us to have a sexy abstract, so to speak. But I think it really does come down to what's best in your hands and what's going to be most reproducible.
So I agree. It really depends on what's good in your hands, and that's where we want to go experiment, because whatever you're good at, you'll be able to get the maximal viewing port. Because really, what you can see is what you can do. So if you're a good beast chair surgeon, you'll know all the techniques and nuances to see that anterior inferior aspect. For the lateral decubitus, I really focus on viewing and going through that with the fellows, being able to see posteriorly, inferiorly, the haggle, being able to get circumferentially around the humerus, all at the insertion areas of the of the capsule. So as a lateral decubitus physician, I think that if you get really good at that, we can actually see the nuances for the most difficult cases. And I think that's where the difficulty is going to come. You're not going to get an outcome study for generic shoulder instability that's going to be different from a Bankart versus doing a beast chair versus a lateral. It's those extremely difficult cases where you actually have to use every little trick in your book. That's when you're going to be able to tell the difference between one position versus another. And these are, these are the few and far between. That's where I think some of these minor minutiae that we're talking about for surgery is going to make a difference.
Can I jump in here?
Please.
Yeah, Ivan, this is Brett. I agree with you, and I think if you want to talk about maybe posterior, that's one where I know, at least going back 10, 15 years ago, a lot of people would say, well, I'm beach for everything, but I like my posteriors lateral decube. And there have been I just think there's a bias in some of these studies that go into it looking for superiority with lateral decubitus position, right? Even using the terms I talked about earlier, like modern technique, right? Which kind of, I guess, bugs me a little bit. But there are two studies that look at posterior repair, right? One from your group, Rachel, I think, and another one that was published in arthroscopy in 2019. And again, both these showed no difference, right? Yet the conclusion of the studies in your paper, Rachel, right, that showed no difference, right? Yet they both say, well, we need longer term, even randomized trials, right, to show a difference. Which I guess implies a little bit of bias here, that we're expecting lateral decubitus to be superior, but I don't know that it is.
Yeah, no, I think part of the thing is the other aspects of shoulder instability that we're dealing with now, because it's more and more common not just to do a Bankart, right? So if there's a subcritical bone loss, and we talk about Hill Sachs being large, to me, it's easier doing a rump massage or dealing with the posterior aspect with in a lateral decubitus position, just like you mentioned, Brett. So in those cases where they have multiple things going on inside the shoulder, it's maybe easier to recognize these and be able to address them at the same time, as opposed to having to come down in a future surgery.
I just want to have Brett on every time we do the podcast so I can have someone that will really take on Rachel. So I'm so pleased that with what just happened. I wanted to get a little bit into the minutia, into the weeds. I mean, we talked a little bit right now about how it's all in how you do it. So let's get a little bit into the tips and tricks specific to the positioning. So Ivan, tell us a little about when you position the patient, what do you think are some of the critical things that really allow you to maximize your intraoperative visualization or exposure?
Right. So positioning, I want to be able to keep, so in the lateral decubitus, I really want to get that glenoid as flat to the ground as I can, because that allows me to get the best access from the front of the shoulder with a view from the anterior superior portal where I stand at the head. To me, the best way of doing that is to lean the patient back about 30 degrees. So I try to get the arm, the bottom arm or bottom shoulder kind of in the center of the bed, lean the upper shoulder backwards so it fits towards the posterior aspect of the bed, and have that bean bag or that sandbag behind forms a nice triangle to hold it in place. Then I reinforce that triangle with a side post so I can really pull back on the arm, really get a posterior directed force on the humerus to be able to see the anterior aspect, and allows me to push the shoulder forward to get a good access to the posterior aspect of the shoulder joint. The 3D model I really do reinforce is that really helps me make minor adjustments to that portal to make sure that I can be perfectly parallel with that glenoid in that posterior portal, because that really allows me to have maximal control of everything inside the shoulder. And that's really the starting off block to make sure everything is stable.
And what are your thoughts, Brett? Are there any like critical elements when you're teaching your fellows and residents where you say you've got to get this right to be able to
I really
visualize
like about
properly in the beach chair?
So there's some things I really like about the beach chair position. I like that I can do my exam under anesthesia in a similar position that I'm doing my exam in the office, which is usually in the seated position. Really allows me to get the patient to relax a little bit. And then I can also do an arthroscopic exam under anesthesia. It allows me to, especially in those complex instability cases where I can really need to titrate my anterior versus posterior and inferior repairs and capsulorrhaphies, and be able to look at how the shoulder moves arthroscopically, which can be very helpful, especially in those really muscular patients that have a harder EUA. I do think that in the beach chair position, I have to be a lot more careful about portal placement. And I need to get really low, especially with my anterior inferior portal, allowing me to really push down on the subscapularis and be able to get to that low kind of 530 position on our right shoulder to get as low of a anterior-inferior anchor as I can get. And that really helps me with my shuttling. It helps me with my preparation. I think a lot of the principles, are the same. I tend to use a arm positioner like Ivan had mentioned, earlier, and there's a few of them out there. They all work very well, but I tend to really hold my arm in a very similar position that what he's doing with the lateral decubitus position. It's usually around 30 degrees or so of forward flexion, a little bit of abduction with distraction. Longitudinal distraction, as well as a lateralization force. You can either have the assistant gently pull on the arm and get a little bit of distraction that way. I've also used a bump similar to what's used in the lateral decubitus position in order to lever the humeral head laterally. You can do it as well in the beach chair position, similar to the lateral decube. But for me, the big key aspect is being in a good position with my portals, especially in my inferior portal.
Good pearls for both positions. I do want to, respond to what Brett said earlier. Our abstract and paper on posterior shoulder instability comparing beach to lateral, as he mentioned, showed no difference. But the conclusions just said low rates of recurrent shoulder instability and high rates of return to sport can be achieved in either position. And additional long-term studies are needed to compare these positions to better understand the potential advantages and disadvantages of surgical positioning. So I would say it depends on the way that you read it. If you're a lateral person, you might say, well, is she trying to say that you need to look more at beach chair? And if you're a beach person, you might say, oh, is she really trying to prove that lateral is better? But we really did try to be objective. And again, the data didn't show that there was any difference, and both are good. So I just want to be clear on that. But speaking of potential advantages, let's talk about disadvantages. So what are the complications each of you guys look out for while you're positioning and during your surgery? Do you worry about the axillary nerve when you're placing your low anchors? Do you worry about traction injuries to the brachial plexus, depending on how you're pulling on the shoulder? Do you worry about lumbar spine complications with positioning, neck complications, or ulnar nerve complications? What are the things you guys look out for? Let's start with Ivan here.
That's probably one of the benefits of lateral. I do find that there's very well, I guess as long as you pad them up, there's very low risk for it. You make sure the spine's well aligned, that you have no issues with the neck. You're using a bean bag they're going to suck everything out of. So once you get them in a comfortable position, you suck all the air out. You make sure the axillary space is open with that hole in there in that number 31 bean bag. And all your bony prominences are well padded. The axilla is well open, so you're really not worried about much. You're only using gravity to kind of pull the arm up, so you're not distracting it more than what gravity would hold. So you're not worried about any traction injuries. And being in a lateral decubitus position, you tend not to have to worry about nerve injuries or axillary injuries because you're not going to be low down enough. You usually can reach everything. You rarely ever need to do a 5 o'clock or 7 o'clock position portals to get down to 6 o'clock on the glenoid face. So I'm not having to worry about going in areas that I'm not used to going to.
And Brett, how about you when you're positioning for beach or actually doing the surgery? Any concerns, anything you really harp on with the residents and fellows that you're teaching? Be careful of this. Anything you're worried about whatsoever, and what are some tips to avoid potential complications?
Yeah, as mentioned, it can be a little bit easier if the patient is able to help with positioning. Obviously, if they're completely anesthetized, you have to be very careful with padding, etc. You always have to be careful, but there is a little bit of a concern about traction to the plexus in the beach chair position, and you have to be able to make sure that you have their torso and their cervical spine and their head aligned and not under undue traction, especially if you're pulling on the arm. One thing I always harp on, because I've seen it before, is the position of the headrest. That, if not positioned properly, can result in an occipital nerve palsy. You have to be careful, make sure you have well padded head position. Other than the other things that that Ivan mentioned as well, and I'm not sure if there's anything else that's peculiar to the beach chair position.
Let's talk a little bit about cuff. I think this is actually a place, Ivan, where you're outnumbered as the only person that's doing lateral decubitus for cuff. Tell us, why are you doing that? Why not beach chair where you can, pull distal on the arm? Tell us the reason why you think lateral decubitus is better for cuff.
So, very, very good point. Probably why I think lateral is better is for the same reasons that lateral, to me, is better for instability. To me, it's more ergonomically correct. I'm not that tall, so beach chair, I find I have to hold my arms actually quite a bit higher to be able to do the surgery that I want to do. I actually changed the orientation of the viewpoint when we look into the surgery, looking like a beach chair. So the acromion's on the roof. So that's what I was taught as a fellow, and I continued that way. And doing a lateral cube, my assist is always beside me or in front of me or somewhere around where I'm standing at the head. So I do work upside down and backwards, but my assist is nowhere in my elbow space. So I got lots of room to kind of pass sutures in a retrospective fashion. So I can actually pass the suture, grab it with a grasper on the other side, and my assistant, who's on the easy side, will be able to hold the camera exactly where I want them to see everything. If I'm going to do more complex cases that's needing grafts or transfers or anything like that, this allows me to place the graft right onto the patient's arm. So I don't need any extra space to do it. It's out of the way. It's easy to orientate all the sutures so nothing gets tangled. And again, my biggest thing for everything that I do arthroscopically is visualization. And for visualization, the lower the anesthesiologist can keep the blood pressure, the less pressure I need to put on the pump, so less extravasation I need to do. So for bigger, longer cases, there really is not much swelling in there, and allows me to keep everything clean and easy to see.
I just want to. I think I'm confused. Where you're standing on? Where are you standing? You're standing backwards and upside down? I don't understand.
Yeah, so I stand at the head. So similar to where I stand for shoulder instability, where we do the anterior superior portal, I actually stay standing there when I do cuff work. So the cuff to me is really upside down. So I actually pass the sutures from posterior to anterior, and I can grab, so using a retrograde suture passer spectrum or something along those lines, and I'm able to grab the suture from the anterior portal with my other hand and be able to shuttle sutures to myself, so make a retrograde suture passer easier.
So you're doing all your passing then with a retrograde suture passage? You're not using
Yeah.
like the okay,
No, I don't tend to use a anti-grade suture passer.
interesting. And then your assistant is standing on the patient's posterior side with the camera the whole time.
Absolutely. So try to find the easiest place for my assistant to go. So they stand there, they have two hands on the camera, and then I can be able to have both hands doing instrument handling.
So where is the anesthesiologist then?
Anesthesiologist in the front, so anterior to the patient where the airway is.
Ah, so you're tilting that you're like turning the bed 90 degrees. It's just interesting to hear the way different people set this up because that's very different from the way we're setting ours up. It's good, but it's just different.
Yeah.
What tell us, Brett? I know you're doing cuffs beach chair. Now tell us why is the beach chair position better for the cuff?
Well, I don't know that it's better for the cuff. I think that it works for me for the cuff. And uh, I guess an interesting question that I have for this group is that, so I mean, I take care of instability patients that have cuff tears, right? And so I just fix them, right? I mean, I fix their labrum, whatever I have to do intra-articularly, then I fix the cuff, right? I guess I always wonder what people do if they're changing positions and they run into something that maybe they didn't see on imaging. Um, I don't know. I think the beach chair position is great for cuffs, and certainly I'm old enough to have done open cuffs, and now I still will do some subscaps open. So it's just very easy, to transition to do other things if you're doing a open tenodesis, etc., or whatever it is that you're doing. It's all pretty natural. But I tend not to. Now I have a lot of colleagues that will do all their instability and cuff for lateral decube, and I have no problem doing it. I think I think the only thing I would have a problem with is if you're not ready to handle what you encounter and you change your course based upon what your planned position is.
Rach, I always think that's the interesting case for the people who are beach chair, people who position some cases beach chair, some cases lateral is this case, the combined cuff labor repair, the instability patient that's usually the 45-year-old ski injury, at least in Salt Lake, that's what it is. How are you doing that case in Denver? When that 45-year-old guy comes because he's jumped off a cornice and dislocated his shoulder and he's torn a supra or he's torn a subscap and there's a labral tear. What are you doing with that case?
Great question. And yeah, same in Colorado. This is that 40 to 50-year-old skier, snowboarder, sometimes even rock climber who has an acute traumatic injury. I think these are tough. I think you have to go with what you're most comfortable with in terms of managing the pathology. As both of our guests here have said, you can accomplish either surgery, both instability and rotator cuff repair in either position. Certainly doable, and the outcomes favor both of these positions. Again, you just have to be comfortable with what you're doing. In my personal practice, I try to go in the position that I think is the predominant pathology. So if this is a big cuff with a subscap, I'm going to go beach chair. I do feel comfortable doing the labrum in beach chair. I just don't like it. It makes me irritated in the OR, and my residents and fellows will be the first to tell you I get a little cranky when I'm putting in those low anchors. And if they have a huge 270-degree labral tear with a small cuff based on the MRI, then I'll go in lateral so that I can attack in a more comfortable position for me, that labrum. And again, when I go up top and try to do the rotator cuff, I grumble a little bit and it's less comfortable because I don't do cuffs as frequently in lateral, but still can get it done. So that's how I approach it. I try to go with what I think is the more predominant pathology. When you're kind of 50-50, I think that that's a little bit more challenging. And I would tend to favor the lateral decubitus position in that case, because again, I'm so much more comfortable doing my Bankarts and my posterior labrums in that position. What about you, Pete?
I agree with you, Rach, that I think that one of the key follow-ups from both of our presenters is that it's really valuable to be comfortable doing both things in both positions for specific scenarios. So I think you heard Brett say earlier he's tried both things in the lab, he's tried both things in his practice, he thinks both can work. I think you've heard Ivan say I can do everything lateral, so I feel very comfortable there, and that if I encounter something unexpected, when certainly I had a case about a year ago where I was doing a leg repair in a 19-year-old gymnast where we incidentally found a full thickness supraspinatus tear that was not well appreciated in the MRI. Like and I felt comfortable fixing that cuff lateral, but you have to feel comfortable with that case. So definitely, I think for the listener, you want to feel comfortable with whatever pathology you might encounter, and you don't want to have that case that's gonna where you're either not going to be able to fix everything that's broken, or you're going to somehow have to reposition intraoperatively. So I think I think the advice exactly what you said is what I do, which is that I try and feel comfortable doing both things because you never know what you're going to encounter, and because often you encounter combined pathologies. I wanted to ask you, Brett, it sounds like you're doing everything beach. Is there anything you're doing lateral? Are there tendon transfers, glenohumeral fusions, or are there any cases where you say, well, actually, that case for me is a lateral case?
Yeah, I guess every once a week when I book a glenohumeral fusion, right? No, I mean I don't do glenohumeral fusions. Who does those? And I'm not doing tendon transfers. Um, uh, and I would say the only thing I probably do lateral decubitus, I do endoscopic snapping scapula, which um, I think is much easier in the lateral decubitus position. That would be about it. Nothing intra-articular glenohumeral, or I know Ivan said he does it for beach for uh, AC work, but I do all that in the beach shift position. I don't do arthroplasty, which I know most people would do that in the beach position too.
Peter, are you doing a lot of glenohumeral fusions? For that to be one of your questions that you just asked?
Well, I've only done 2 in 5 years, and I did one of them lateral, one of them beach, but I was just trying to come up with rare cases here. Let me ask, so I think it's interesting that you're doing your scapothoracic dorsectomies, uh, lateral. Ivan, how are you doing that case? Do that case I do that case prone. Are you doing that case prone, lateral?
Well, I've never done that case. We had one come up. I'm not sure how to tackle it, but I know where to send them now.
You'll send them to Denver. Rachel's really good at that case.
No, Pete loves those cases in prone, as you heard. He loves them. One position we haven't talked about today.
I've done one
Any
prone, and I had a bilateral case, Pete, and I did it prone, and he had one at a time basically. They got actually IV access in the leg, and I was able to do it prone. And I don't know how I got talked into doing that, and by the patient, but he had a lot of extravasation around front, and they had concerns about uh, extubating him. So yeah, the prone, I moved to lateral decube, and I found that it would be a little bit easier for me.
Wow, talked into both sides at the same time. I think we're getting to the point where we've heard it all. Is there anything else you guys wanted to add? Anything else you wanted to say that didn't get mentioned? Ivan?
No, I think you very clearly said it at the end, summarized it well. It's really important to get good at whatever you're doing, right? So and there is a benefit to choosing one position so that you can tackle both instability or intra-articular work and subacromial work. So there's definitely advantage to each thing. It allows you to do those, non-standard cases, 5% of your practice, to be able to tackle those things you don't anticipate, to make them easier.
What about you, Brett? Anything else you want to mention that didn't get mentioned?
No, I think I really enjoyed being part of this podcast. I think I would end with what I started with that. I think we can do a really good or a really bad work in either position. And I guess I would hope that we can kind of end the debate and maybe both sides agree to disagree, and maybe not position shame each other, saying that one's better than the other. I think the key is what works for you in your practice at your facility with the team that you have.
All right, listeners, you heard it here. No more position shaming, and let's all just do good work in whatever position we scope our shoulders in. We want to thank both of our guests. That's really all the time we have for today's podcast. Thank you, Ivan. Thank you, Brett, for joining us. The discussion was outstanding. And for all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.